Good morning, everyone. My name is Devi Ngoma. Um, I'll be taking you through adult cataract. So this is the outline of my presentation. We'll define what a cataract is. We'll look at the epidemiology, the anatomy of the lens, the different classification of cataracts, the risk factors, pathophysiology, clinical features, the differentials, as well as the management. So to define what a cataract is, this is an abnormality of the ocular lens which is characterized by clouding and discoloration of the lens. And cataracts account for about 40% of global blindness, representing about 16 million people. Age-related cataracts is the leading cause of blindness in the world today. And the second leading cause of visual impairment following refractive errors. So cataracts occur everywhere, but in all the aging population. But the inequity in eye care means that 99% of these blinding cases are seen in developing countries, and it is a very treatable condition, a very treatable cause of blindness. Just to have a recap of the anatomy of the lens, which I've already done. So this is as we can see, this is a structure that is suspended by the zonules, which are attached to this ciliary processes. So the normal anatomy of the lens. So this is a picture. Let me just get a pointer. So this diagram is showing a cross section of the lens. So the lens has got four main parts. So it has got the nucleus, it has got the cortex, it has got the epithelium inside, and it's enclosed by a capsule. So the anterior side of the lens has got an epithelium, whilst the posterior side doesn't have an epithelium. This is the equator of the lens, and this just showing the zonules attaching to the pores of the lens. So a lens with cataract will have opacifications which can occur in the nucleus of the lens. They can also occur in the cortex, as well as in the capsule of the lens. And we know that one thing I forgot to mention is, the lens is a very important structure that helps in refracting light. So the cornea provides about 2/3 of the refraction of light before to focus it on the retina, whilst the lens provide about 1/3 of it. So the lens is a transparent structure, as we already learned in the anatomy, and there are several factors that contribute to its transparency, and one of it is the regular arrangement of its fibers. And when this arrangement of the fibers is disrupted, it causes the lens to become opaque. So that is what a cataractous lens is. Classification of cataracts. So there are many ways we can classify cataracts, and it can be according to the age of onset. As we've already seen, we have pediatric cataracts which have got their own different causes. And in this presentation, we're focusing on the causes in adult cataracts. We can also classify them according to the cause, the morphology, the grade of opacification, as well as the maturity. So we'll look at some of these different classifications in details. So the first one will be classification according to etiology. Cataracts can be classified as age-related, cataracts in systemic disease, secondary cataracts, as well as traumatic cataracts. So this age, the first one, the age-related cataract, is also known as a senile cataract, and this senile cataract usually occurs. It occurs mostly after the age of 50, and it is caused by the natural aging process of the lens. So there are several factors that contribute to the development of senile cataracts. One of it is protein. The first is protein aggregation. As people age, the proteins in the lens can denature and aggregate, forming clumps that scatter light and causing the lens to be cloudy. The second one is oxidative stress. Over time, the balance between the reactive oxygen species production and the body's antioxidant defense can become disrupted. So this increased oxidative stress can damage the lens proteins. Ultraviolet radiation. So we're talking of age-related cataracts. So the longer you've lived, it means the more you've been exposed to ultraviolet radiation. So this ultraviolet radiation from the sunlight can actually induce oxidative stress and damage the lens proteins, which will cause cataracts, as well as genetic factors, because this influences susceptibility to cataract formation. It's not everyone who will develop cataracts at the same age. Some will develop it earlier than others. So certain genetic variations may accelerate the aging process in the lens or affect the response to environmental factors. So there are several factors that contribute to development. These are just a few of those factors. The second classification is cataract in systemic diseases. So cataracts can occur in several diseases. Some of them most common ones are the ones I've mentioned, are the ones that are on this slide: diabetes, neurofibromatosis, myotonic dystrophy, atopic dermatitis. So the first one, diabetic diabetes mellitus. So there are different. There's been different mechanisms which have been proposed as in how diabetes causes cataracts. The first one is through sorbitol accumulation. So excess, a person with chronic diabetes has got excess excess glucose in the blood, which can enter the lens, and it is converted to sorbitol. This glucose is converted to sorbitol by an enzyme called aldose reductase, and this sorbitol cannot easily diffuse out of the lens, and it creates an osmotic stress, so thereby it draws water into the lens, and the lens swell up and they become opaque, thus forming a cataract. Another mechanism is glycation of the lens proteins, thus altering their structure. With neurofibromatosis type 2, so neurofibromatosis is a condition in which you have a genetic mutation in the neurofibromatosis type 2 gene, and this affects a protein called myelin, which affects cellular signaling pathways and regulation of cell growth. So this dysfunction can lead to abnormal cell proliferation and changes within the lens in the eye. With myotonic dystrophy, It can cause an accumulation of abnormal proteins in the lens due to mutation of a gene called DMPK, the dystrophy myotonic protein kinase, leading to defective RNA production, and that also causes a defect in the proteins in the lens. And with atopic dermatitis, this is an allergic. This is an inflammatory condition, and when sometimes it can actually even extend to affect the lens, thus causing cataract. And also with atopic dermatitis, the treatment mostly we use corticosteroids, and corticosteroids are well known to cause cataract. The other classification is secondary cataract. So, yes, I'm coming.
Receiving?
No, I'm just trying to come up with the presentation.
Steady. Do you have anything more?
Yeah.
Wow. Just try to write to come up with my own presentation. It should be less than 20.
Anayonjo? Anayonjo?
Yours is more than 20.
Mine is 27.
Yeah, I can see the reaction.
Huh?
I can see the reaction.
What reaction?
The reaction to my words.
Why mbali chibaguru?
I know. Nasipa nikampa numbers okay. This time okay.
And then Madam Abuela.
I am true. This I can have things to have certain Abuela and then I can do this.
With a secondary cataract, it develops as a result of other primary ocular disease. So, for example, when you have diseases like chronic anterior uveitis, which cause inflammation, can affect the lens as well. Acute congestive angle closure, with glaucoma, angle closure glaucoma, high myopia can also cause cataract. How high myopia causes cataract? The other classification of cataracts is traumatic cataracts. This occurs due to penetrating trauma, as we learned yesterday. So blunt trauma may cause a characteristic flower-shaped opacity. Electric shock can also cause cataracts, but it's a very rare cause. Infrared radiation, if intense as in glass blowers, may rarely cause true exfoliation of the anterior lens capsule. Ionizing radiation exposure, such as for ocular tumors, treatment may cause posterior capsular opacities. These may not manifest for months or years. And then looking at the morphological classification. So this will depend on where the cataract has actually formed on the lens. As I already showed you the different parts of the lens. So you have the nucleus, the capsule, the cortex, as well as the pores of the lens. So okay, let me just show you a diagram. So this is a diagram showing where the cataract can actually occur. So if it is occurring in the nucleus, then you're calling it a nuclear cataract. If it's occurring, so this is the anterior part of the lens. So if it's occurring in the anterior pore, this one is occurring in the cortex. This one is occurring in the posterior subcapsule and the posterior capsule of the cataract. Yeah. So this is very important when we'll be looking at some of the clinical presentations, because depending on where the cataract is, it will affect how you're able to view images, depending on the level of, for example, so if it's all right, I think I'll get back to that later. All right, but first of all, let's talk about cataract maturity. So we have we can classify the maturity of cataract as immature cataract, in which the lens is partially opaque. It's not fully opaque. And when you see you also have a mature cataract, in which the lens is completely opaque. A hypermature cataract has a shrunken and wrinkled anterior capsule due to leakage of water out of the lens. And then you also have the Morganian cataract. I think we talked about it in the pediatric cataract handout, where you have it's still a hypermature cataract, but then there's liquefaction of the cortex, and the nucleus sinks inferiorly. So this is a picture showing the different maturities, the different cataracts according to maturity. So this is an immature cataract. So as you can see, it's not fully opaque. So there's this. It shows this black margin here, which is the iris shadow. So this is characteristic of an immature cataract. This is a mature cataract. You can see it's fully opaque. This is a hypermature cataract. So it's fully opaque, but there's also some wrinkling that has occurred due to leakage of water out of the lens. The Morganian cataract, so there's liquefaction of the cortex, so it liquidifies, and the nucleus of the lens sinks inferiorly, and you can also see some calcium deposits in the lens, on the lens capsule. Some of the risk factors for developing cataracts include age, as I've already alluded to, sunlight exposure, which can also damage the lens. Smoking will cause reactive oxygen species, which also lead to damage of the lens. Alcohol as well, dehydration, radiation, corticosteroid use. So corticosteroids can also increase the production of reactive oxygen species in the lens. The oxidative stress caused by these reactive oxygen species can damage the lens proteins and fibers, leading to their aggregation and the formation of opacities, characteristic of cataracts. And other systemic conditions that I mentioned earlier, like diabetes, neurofibromatosis, atopic dermatitis, myotonic dystrophy, and other systemic conditions. So now to go into the pathogenesis. So the pathogenesis would depend on the cause, because I think I've already explained a little bit of the pathogenesis in the previous slides. So how those different factors, some of the factors is not very clear. Although a common pathway appears to be protein denaturation, for example, by oxidation. So aging causes lens protein changes. This causes fluctuations in the refractive index of the lens, scatter light rays, and reduce transparency. Change in capsule permeability reduces the rate at which water and metabolites enter the lens, causing opacification. Trauma directly compromises the lens capsule that leads to cortical opacification at the site of injury. The resultant cloudy lens lack the ability to transmit and focus light rays on the retina. So when you have a lens that has got a cataract, you won't be able to see images clearly, because there's a scattering of light as the light enters the lens, so your image will be very blurry. And the other clinical features, apart from reduced visual acuity, you can also have reduced color appreciation. You can also be seeing glares especially when there are bright lights at night, so you see multiple flashes of light, and it's very hard to drive. Monocular, you can also have diplopia, where you have double vision, or even triple vision or multiple vision. This happens because as at times the nuclear changes are concentrated in the inner layers of the lens, resulting in refractile area in the center of the lens, the so-called and this is called lens within a lens. So it's like you formed another lens within a lens. So this one will be refracting light. The general lens, will also be reflecting light. So you're gonna be forming like two different images, or even multiple images on the retina. You also have a clouded blood or dim vision. It can also present with a change in refraction, typically myopic shift in nuclear sclerosis, or increased or changing astigmatism. So this myopic shift, it's when a patient, alright, I think I'll get back to that later. Alright, so some of the differential diagnoses for cataract include age-related macular degeneration, diabetic retinopathy, glaucoma, refractive errors. So the workup includes, you have to take a thorough history, like how the condition, you're gonna ask the age you're gonna ask the patient's age, how it started, the progression of the symptoms, the general past ophthalmic history, family history, medical history, just to assess for the risk factors. You're going to perform a physical examination where you're going to do a visual acuity testing, pupillary reaction testing, and check for the red reflex, which will be absent in cataract. You can also perform a slit lamp examination, as well as a brightness scan, where you're going to see this, the lens will have, it will show this opaque appearance. So I mentioned about myopic shift. This is caused by an increase. So a cataract should be suspected in any patient in who complains of painless vision loss. And in many patients, there is an increased nearsightedness before there's an opacity of the lens. So the first thing they'll notice is I have a decrease in vision. And this increase in nearsightedness is called myopic shift. Is caused by an increase in the refractive power of a lens that is gradually becoming characterized and can continue as opacity develops. So with old age, what happens? We learned that with old age, a patient can develop presbyopia, where you have difficult with near vision, but you can see distant. Your distant vision is actually normal. So mostly they struggle with reading maybe small prints on a book. But when you're developing cataract, what happens is now the patient will be like, I in the past I couldn't see on I couldn't see while I'm reading maybe a book near with reading a book. But now I can actually see. I can actually see well, and my vision is fine. And you can also be suspicious of a cataract, because the cataract will increase the refraction power of the lens. So with the management, the definitive treatment for cataracts is surgery. I mean, you can if it's not very severe or not affecting the patient's daily activities, it's not necessary to perform surgery. So you can actually try to just alleviate the symptoms. Maybe if they're having glares, you can actually provide them with maybe glasses, just to correct some of the refraction errors they might be having. Um, and also you have to treat the systemic disease that they might be having. So with the surgical options that are available, you can perform a pharmacoemulsification, which uses ultrasound to break the cataract, and it is removed via suction. Also, you can perform an extracapsular cataract extraction, where the posterior lens capsule is conserved. You remove the lens, but you preserve the posterior lens capsule, and where you can actually insert the intraocular lens and intraocular lens. With the intracapsular cataract extraction, you remove the entire lens, including the posterior capsule and the zonules. But there's higher risk of complications with this procedure. You can have retinal detachment, corneal edema, vitreous loss. So this procedure is not done as often these days because of the risk of complications. So this picture just shows this intraocular lens, and you can see it right here. It's been inserted into the eye. So with cataract surgery, some of the indications would include to improve the vision in individuals with significant cataract-related disturbances, significant difference in refractive power between the two eyes, also cataract which has caused glaucoma is an indication for surgery. But the contraindications include visual disturbance manageable with corrective lens, vision not expected to improve after surgery, high surgical risk. So you can just manage these patients conservatively. Okay, so These are my references, and thank you. Wait, how do I stop it?